Senator McCann. Senator Bayer.
Here.
Senator Camilleri.
Here.
Senator Heisinger.
Here.
Senator Tice.
Here.
Senator Daly.
Here.
Madam Chair, you have 8 members present. There is a quorum.
Thank you. I will now entertain a motion to adopt the meeting minutes from March 12th. So moved by Senator Irwin. Without objection, the minutes are adopted. Today, we'll be taking up Senate Bill 3, 4, and 5, brought to us by Senators Camilleri, Senator Kleinfeld, as well as Senator Schink. And these bills will not be anything new, as we took this up last legislative term. There is an S1 substitute for Senate Bill 3, which we will adopt prior to hearing testimony. Then we will hear testimony on the bill as substituted. I will entertain a motion to adopt the S1 substitute to Senate Bill 3. So moved by Senator Camilleri. Will the clerk please call the question?
On adopting the S1 to Senate Bill 3, Chairwoman Kavanaugh.
Yes.
Senator Irwin.
Yes.
Senator McCann.
Yes.
Senator Bayer.
Yes.
Senator Camilleri.
Yes.
Senator Heisinger.
Yes.
Senator Tice. Senator Daly.
Yes.
Madam Chair, there are 8 yeas and 0 nays. The substitute is adopted.
Thank you. We will now hear testimony on all 3 bills as substituted. Senator Camilleri and Senator Schink, I welcome you up to committee for testimony.
I think I'm just going to stay here if you don't mind.
Awesome.
Cool. Well, thank you, Chair Kavanaugh, and thank you, colleagues. It is a great day to lower the cost of prescription drugs for our residents. Thank you for the opportunity to provide testimony on these bills, Senate Bills 3, 4, and 5. I'm here today because Michigan residents deserve to have access to prescription drugs that they depend on to have the ability to go to work, take care of their families, and live a healthy and dignified life. We've heard countless stories of our neighbors being forced to choose between the medications that they take and other expenses such as groceries or rent as a result of profit-motivated decisions made by big pharmaceutical companies. I'm thinking today of the woman in Grosse-Ile who told me that one treatment for her disease last month was suddenly $2,000 more than the previous one, with no difference in the medicine. She told me it was taking up all of their family's extra income. I'm also thinking of a man in Belleville who told me that he'd be filling his prescriptions in Canada because it's $250 per month without insurance over there versus nearly a $1,300 a month expense here. Or the young mother in Southgate who told me she's been rationing asthma inhalers due to the cost. Our package would help remedy this financial burden on our neighbors by establishing a prescription drug affordability board right here in the state of Michigan. This board would be responsible for reviewing the costs of the most expensive medications and look for instances of price gouging, and through extensive research and analysis, have the ability to set upper payment limits to avoid exuberant costs and keep prescription drug costs low for Michigan residents. The individuals who would be appointed to this board would have expert knowledge of this field and no personal or financial ties to the pharmaceutical industry. We want an independent board making these calls. A PDAB is a common sense, independent way for our state to hold Big Pharma accountable and create a transparent process for us to help reduce the out-of-pocket costs that our constituents face just to ensure that they can stay healthy. I first introduced PDAB in 2023, and we find ourselves here again in April of 2025 with a very different situation when it comes to access to healthcare. As we speak, the federal administration is doing everything they can to eliminate cost-saving policies and allow their big pharma allies to extract as much profit as possible as they can from the American people. With Medicare and Medicaid in the crosshairs of Republicans in DC, it is more important than ever that we can take action here in Michigan to deliver savings to our residents wherever we can. I ask you today to support this package so we can establish a prescription drug affordability board right here in our state so that our neighbors can afford their life-saving medications. Last thing I'll just say, when I think about the personal testimony that people have provided to me on this legislation, I think of a man who came to my Riverview Town Hall, a staunch conservative. He's come to a lot of my events. He does not agree with me on almost anything, okay? We've had many a conversation. But we had a town hall on this in 2023, and he was there. And I was expecting him to, again, disagree with me like he did on most other things. But he raised his hand publicly, and he said out loud, Senator Camilleri, you and I have had many a conversation. We don't agree on much. But on this, I am with you. I want you to lower the costs of what Big Pharma has been doing to families like mine, lowering the cost of prescription drugs. And this is a testament to the fact that this is not a partisan question. No matter your political affiliation, lowering the costs of everybody's medicine should be something that we should all agree with. So I urge you to support this legislation and happy to entertain any questions.
Thank you, Senator, and I appreciate all bill sponsors of bringing this bill package back in front of committee. I do think, even as Leo Chair, as Michiganders, we're really choosing either to feed our children. Or even the price of drugs just to stay healthy. And so I appreciate you bringing this forward. Any questions from committee members before we move on to other testimony? No, thank you so much. And next, I would like to welcome Dr. Rob Davidson, MD, PHS, Executive Director of Committee to Protect Healthcare, and Dr. Jane Kortz, Secretary of Michigan State Medical Society, in support of the bills. Thank you for being here today. Yep, there's little buttons at the base of the mic. Perfect. There you go.
Is it on now? All right. I guess I'm leading off, so thank you. Can you hear me okay, everyone? All right, thank you. Good afternoon, Honorable Chair Kavanaugh and esteemed members of the committee. Thank you for allowing me to testify today. My name is Dr. Jane Kortz, and I am an internal medicine primary care physician. I'm here speaking on behalf of Michigan State Medical Society, where I have the honor of serving as the board secretary. As a physician, I often prescribe medications. When I prescribe medications, I review the indication or reason for the medication as well as the side effects with my patients. For many years, I have started these conversations with the caveat that the first side effect of any med is cost, and then we discuss the other side effects. I wish I could tell you that I'm just kidding about this first side effect. Unfortunately, I am not. And this first side effect is becoming a more significant side effect every year. Prices for the most commonly prescribed medications for older adults have increased more than 10 times the rate of inflation within 5 years, and prescription medication costs continue to rise. As a physician, I greatly appreciate the life-improving and life-saving medications that are researched and developed by pharmaceutical companies. I appreciate access to these medications for my patients, at least when I electronically prescribe the medication and send the script to the pharmacy. However, my patients all too often advise me that they did not pick up a prescribed medication, reduce the dose by cutting a pill in half, or stop taking the medication due to the high cost. Sometimes I hear about this med change from the patient promptly, and we work together to seek a lower cost supplier or lower cost alternative med. Sometimes I do not hear about this med change until the patient is experiencing a medical crisis, such as a patient who needed an albuterol rescue med inhaler for an acute asthma attack. I also had a patient who needed to pay the full annual insurance deductible to obtain a single dose of a monthly long-acting injectable med for opioid use disorder, risking relapse, opioid-related overdose, and possible death without this medication. There are many other examples that could be shared. We have patients who must make decisions about purchasing essential medication, paying rent, or keeping food on the table. Nearly a third of Michigan residents have stopped taking their prescription medications due to cost, and 60% of our older adults have reported concerns about the cost of their essential meds. In addition, the high cost of medications may lead to med changes by our patients that can result in other increased healthcare costs due to additional office visits, emergency department visits, or hospitalizations, with a reduced quality of life for our patients due to worsening of their medical conditions, including the risk of death. While pharmaceutical companies should be reimbursed for their R&D efforts with enough of a profit to reinvest for R&D of new medications, the pharmaceutical company industry brought in $29 billion in net profits during a recent 3-month period. The PDAP leverages the current market systems and operations already in effect across the healthcare marketplace to lower prescription drug costs at the top of the supply chain, in turn lowering costs for all participants in the market downstream, including patients. States across the country, including Colorado and Minnesota, have already enacted PDAB legislation on behalf of their citizens. Our patients deserve access to prescription medications at a price they can afford. Please pass this legislation so that physicians and other healthcare providers can help our patients stay healthy and thrive. Thank you.
Thanks, Dr. Kortz. Happy to be here with you. And thank you, Chairwoman Kavanaugh and members of the committee for the opportunity to appear before you today and voice support for the Senate Bills 3, 4, and 5. My name is Rob Davidson. I'm the Executive Director of the Committee to Protect Healthcare. I'm also an emergency physician in rural West Michigan. Actually, I was doing the math the other day. I've been an ER doc. In a couple months, I will have been an ER doc more than half of my life. So I've been doing this a while. And throughout my career, which has now been a bit, I've seen firsthand how high prescription drug costs hurt my patients, especially vulnerable children and seniors in the state. Any doctor will tell you how hard it is when you have a patient who can't afford the medications, and we see it all the time. I was here a couple years ago and testified and, told some stories. These stories, unfortunately, just keep happening. Not sure what that is. I remember specifically a gentleman coming in at 3 o'clock in the morning and speaking of albuterol inhalers and rescue inhalers. He was gasping for breath. He was clutching an empty inhaler. Should I wait a second? Can you hear me
Yes,
okay? I'm fine.
Well, this legislation is so great that
Yeah.
you brought
There you go.
a marching band
Yeah.
to talk about it.
Yeah.
I do think they're passing, so.
Okay.
Yes.
I think we're good.
I
I've often
appreciate
thought
that.
what I had to say might warrant that, but I never had that happen before. No, I remember him coming in 3 o'clock in the morning. He was a truck driver in his 50s, and he was clutching this inhaler, gasping for breath. We had to put him on non-invasive ventilation. It's almost like being on a ventilator with a mask, which many of us remember from COVID, and had to admit him to the ICU. And we asked him, well, why didn't you use your inhaler? He said, well, I ran out last week, and I couldn't afford to get another one. So this guy could have gotten an inhaler that should cost pennies. Truly, has been around so long. I've been on these inhalers since the 1980s, and yet this guy ended up in the ICU because he couldn't afford the inhaler. I had another patient, a woman who was prescribed a prescription drug, Eliquis, which is a blood thinner for a blood clot in her leg. And if you don't take these, that blood clot in your leg can break off, go to your lung, and it can kill you. Well, she took it for a bit. She got a coupon. She got a coupon from the ER and was able to get it for a month. And then after that, couldn't afford it and just didn't take it. We saw her a couple months later with a blood clot in her lungs. Thankfully, she didn't die, but she ended up on IV blood thinners, ended up in the hospital for a number of days, something that could have been prevented had she been able to afford that life-saving drug. I know last time I was here, folks from pharma talked about coupons as one way that they made drugs more affordable. But actually, if you look at a study in 2023, coupons actually increase brand name drug sales because it steers people into brand name drugs. It's kind of like a drug dealer saying, first one's on me, and then you have to keep coming back. The effect of coupons actually led to an 8% increase in overall drug costs rather than just having affordable drugs in the first place. As we know, these stories of our patients are common. Dr. Kortz and I know that, especially true for patients in rural areas where I work. They have less access to health care, they have fewer options for affordable prescriptions, and the non-adherence rates for drugs are much higher in these areas. A recent survey found that more than half of Michiganders has skipped or postponed health care, including filling prescriptions, because of cost. And in the same survey, they told the survey folks that 91% of them said that elected leaders should do something, should take proactive measures to reduce health costs and reduce the cost of prescription drugs. It's endangering people's lives. It's unnecessary. I'm proud to say that with the Committee to Protect Healthcare, we have supported and continue to support PDAB legislation here, but also in other states. We helped pass a PDAB in the state of Colorado and continue to provide input for their work. Colorado's PDAB has already identified several prescription drugs as unaffordable for Coloradans, such as Enbrel, Cosentyx, and Stelara. They actually had another drug, and I forget the name, but that they investigated, and pharma opened their books, and they had a frank discussion, and they decided it was affordable, that they had the ability in the state to make it affordable, and they didn't put this on their list. So this is not an attempt to penalize pharma, take away their ability to recoup costs. It's just a way to have them open their books and let people know, why are you charging so much for this drug? And if it's deemed unacceptable, they can then regulate it. We're happy to see, as physicians, PDAB bring together all the stakeholders, patients, families, community members, individuals affected by rare diseases, doctors, and health experts. These stakeholders all have a voice, and in places like Colorado, they're collaborating to find solutions that work for patients. This is an example of the process working as intended. They crack open the books and they review all of the information. PDAB strengthened the doctor-patient relationship because we actually get to provide for the patients what we've been trained to do, and people can take their medications we prescribe them. When they can't afford the medications, they don't have to struggle to say why they're splitting pills. I know patients come in and they're kind of embarrassed if they're supposed to be on a drug and their blood sugar's off the charts because they haven't been taking it, because they fear we're going to look at them and feel like they did something wrong, when really the system is failing them and these high drug prices are failing them. They can't, if they could afford them, they could just take them and they move on and they wouldn't have to come back. But costs keep going up, forcing many people to choose between buying food or buying their medications, even as drug makers and big pharma rake in billions of dollars in profits. Despite the reality, the Trump administration wants to eliminate provisions that allow Medicare to negotiate lower drug prices. And now experts are predicting that the Trump administration's one-size-fits-all tariff scheme is likely to drive prescription drug costs even higher. The vast majority of generic drugs actually come from overseas and would be subjected to tariffs. Prescription drugs only work if my patients can take them. For these reasons, we urge the committee to approve Senate Bills 3, 4, and 5 and help establish a PDAB here in Michigan to reduce the high cost of prescription drugs. My patients need action now. Thank you very much.
Thank you for your testimony. I do want to apologize for the background noise, but this legislation is very important, so I don't want to put anything off. So apologies for that, but I do want to open it up for any questions for committee members. We do have one from Senator Tice.
Thank you, Madam Chair. And I do want to say to committee members and to people who are testifying, if you want this not to be a political issue, stop making it a political issue. But that said, so PDABs are currently in Colorado, Minnesota, Oregon, Washington, New Jersey. Their goal has been to lower the price, and you commented that they have, but I haven't really seen it. What is it that we're doing differently here, or what is it that they've done differently that has actually succeeded in the elements where you're suggesting that it's working?
Yeah, they're farther along in the process than we are here in Michigan. In Michigan, it passed the Senate last time. It didn't get any further. We're hoping it gets all the way.
So what is our bill doing differently, or what has happened differently in the places where you suggest that it's worked?
Well, they passed the PDAB, and it's worked because they've now identified these drugs. Now they have to set these upper payment limits. So the problem is when these bills come before different chambers in different states, pharma spends untold millions of dollars, right, lobbying. They have just an exorbitant amount of money and lobbying power to stop these in their tracks. I know in the state of Maryland, it was limited to just state employees, and now they've expanded that to have the PDAB affect everyone.
Is there a reason why they expanded it? Is there anything in other states that we're seeing are working to lower those prices, and as to why we continue to try to make it a nonpartisan issue, more of a Michigan resident issue?
Yeah, and again, I think the question about partisan, I'm just highlighting what's happening at the federal levels, why Michigan has to take action and states have to take action. I think the issue is pharma has put up so many roadblocks, they haven't gotten to the point of actually setting those numbers and seeing that direct effect on patients. We know that setting these upper payment limits, but I think sitting here dragging our feet in the state of Michigan because it hasn't exactly happened somewhere else. Everyone's at a different stage of this process. We shouldn't just sit back, I think, and wait so other people in other states can afford their drugs before we afford that ability to people in the state of Michigan. I think we should be pioneers in this because I think we know it is such a critical issue. We can't just sit back and put our finger up and test the waters and hope we can have someone else lead the way. I think we should be leaders.
Yeah, and with 1/3 of Michigan residents not taking medication due to the cost, I think we need to do something. I do have a couple other questions. Senator Huizenga.
Thank you, Madam Chair, and thanks for your testimony today. And I think that it's fair to say that we all want to do things to reduce cost for our residents. My question is more operationally, especially you're in the hospital setting, Medicare reimburses at ASP +6 for these pharmaceuticals that come in there. The state of Michigan has taken that same pathway and reimburses at ASP +6 for Medicaid. How do we reconcile the likely differences there if we set upper limits that would be in conflict with Medicare and Medicaid first of all? And then secondly, are we going to abandon the Medicaid reimbursement model too? Because that runs the risk of harming physicians who are providing these vital products as well.
I will honestly leave that to other experts. I've always been taught to not answer questions I don't know the answer to. So as a physician, I see this impact on my patients. As an advocacy organization, we critically see the need for this change. If Dr. Kortz may have some specifics about that.
Actually, Senator Huizenga, appreciate the question. And again, we have other people with, testimony who can probably respond to that question better than I can. With this bill, with the upper price limit, some of that does not affect some of those programs that you're referring to directly because that price limit is all payers statewide across the state. So it doesn't necessarily affect those programs directly, but I'll let someone else address that much better than I'm not going to be very eloquent there, but.
Thank you, and we will have other testimony, so I appreciate your testimony, and thank you. Next, we're going to welcome on Zoom Morgan J.M. Halloran, Director of State Policy for Pharma.
Hi, good afternoon. Can you hear me okay?
Yep, go ahead.
Great. Thank you so much for letting me be here today. My name is Morgan Halloran. I'm Director of State Policy at Pharma. And we really appreciate you including the industry in today's discussion regarding the Prescription Drug Affordability Board, or PDAB, legislation in SB3, SB4, and SB5. Pharma opposes the entire package, but I'm going to focus my testimony today on SB3. I think we can all agree that we need patients to be able to both afford and access their medications, and no one should have to choose between paying for basic necessities and filling a prescription. Unfortunately, we believe the PDAB will not have the intended effect of lowering patient costs, and in fact could actually hurt access to critical medications. In the 6 years since PDABs were first enacted, not one patient has really seen a benefit from their actions, which is really concerning. A recent white paper released by the Partnership to Fight Chronic Disease surveyed both regional and national health plan payers, and they found 77% of health plans believed UPLs would disrupt patient access to prescription drugs due to coverage changes, tiering adjustments, increased cost sharing, or supply chain complications. And PDABs not only create boards made up of unelected members who can arbitrarily set prices that won't necessarily reduce patient costs, but some, like SB3, also empower the members to set an upper payment limit, or UPL, that has been discussed. And this could be placed on all purchases and reimbursements in the state. But legislation like this could really reduce the availability of life-saving therapies in the state. If a payer cannot obtain a therapy at a state-prescribed price, or if a pharmacy or dispensing provider can't stock the drug because it also can't meet the UPL, then the medicine may simply not be available to patients, which is a real concern. We also have concerns that the PDAB legislation threatens to reduce the development of new medicines, and which would undermine U.S.'s global leadership in pharmaceutical innovation. This provides better health outcomes for patients and their families. Government price setting diminishes the incentive for biopharmaceutical manufacturers to invest in research and development of new medicines. And history has shown that when foreign governments do set prices of medicines, R&D investment and innovation decline. The fact is that this system of innovation that we have here actually works very well, and new treatments are quickly able to get to patients, improving their lives and generating savings across the healthcare system. Analysis confirms that total spending on medicines is a small share of U.S. healthcare spending, between 6 and 15%, and that medicines prevent disease complications and then reduce the need for costlier forms of care later on. PDAB legislation like SB3 focuses on the list price, but ignores the reality of deeply negotiated discounted prices that health plans are actually paying. The legislation fails to account for the role of middlemen and other actors in the supply chain who have real control over the prices that patients are paying at the pharmacy counter. Out-of-pocket costs for consumers are continuing to rise, even as rebates and discounts from manufacturers have totaled more than $356 billion in 2024. And much of that is not making its way to offset patient costs at the pharmacy counter. Some patients are still paying the full list price for the drug, while health plans and pharmacy benefit managers are actually retain manufacturer rebates on those same drugs. So this legislation overlooks the critical role insurers and PBMs play in driving the out-of-pocket cost patients face at the pharmacy counter, which we really believe is the root of the affordability problem. It's important to note that nationally drug prices growth is slowing and flattening despite claims. When you account for rebates and price concessions, net prescription spending has risen at or below inflation for 5 years running. And the average net price growth is projected to decline between 1% and 4% annually through 2028. So there's no evidence, like was kind of stated before, that the PDAB policy actually works or directly benefits patients. While other states have passed PDAB, not one state has successfully implemented a UPL in the 6 years since they were enacted. The programs are also extremely costly to establish and implement. To date, states that have implemented the PDAB have spent millions, but have yet to generate any real change or savings at the pharmacy counter for patients. And it's worth noting that the states with the most stringent provisions, such as UPL making authority, are the ones that are spending the most and still showing no impact. As I mentioned earlier, other players in the supply chain directly impact how much patients pay. And PBMs and insurers, not manufacturers, dictate how much patients pay for prescriptions at the pharmacy counter. Through coinsurance and deductibles, PBMs and insurers are passing more and more costs onto patients. A recent BRG study found that manufacturers only retain 49.9% of brand medicine spending, and the rest is going to other players in the supply chain. What patients really need are concrete reforms that lower their pharmacy costs at the counter, such as making monthly out-of-pocket costs more predictable, making cost-sharing assistance count toward a plan's out-of-pocket maximum, or requiring that negotiated savings on medicines are shared with patients. And all of these policies can be implemented without government price setting, which can have the unintended consequence of reducing options available for patients. I previously mentioned the white paper by the Partnership to Fight Chronic Disease, and in an interview with health plan executives, there was really one clear takeaway, and that was that a UPL affects insurers and PBMs directly, not patients. Insurers, PBMs, and other players will continue to make decisions about what patients pay out of pocket and any conditions patients must meet for coverage. Insurers confirm what patient advocates fear, that UPLs will not lower patient costs and will increase barriers to access. Patient groups here in Michigan are recognizing this, including CSRO, MSHO, Each Coalition, and the Value of Care Coalition, who are also sharing their concerns. We agree that discussions about affordability of medicines are critically important, and we recognize that reforms are needed. But arbitrary price controls focused on just one part of a very complex supply chain won't address the systemic issues that drive patient costs. I appreciate your time today, and I'm happy to take any questions.
Thank you for your testimony and being here. Any questions from committee members? Senator Camilleri.
Thank you, Madam Chair. Thank you for the testimony. I have a couple things I just want to correct the record on. First of all, the federal government has been spending a significant amount of research money at our institutions and the NIH, which have now been cut by the federal administration. So it is not exactly the fault of, folks at the state level when it comes to some of those research dollars being removed from the process. Innovation has been supported by our government for many years, and that's an important part of this decision, while Big Pharma continues to make record profits. When it comes to access to medicine, I think it's critical that people be able to afford that medicine. And part of the problem with the data is that people are not purchasing the medicine because they can't afford the list price, and they can't afford it after their insurance pays what they cover. So that is a challenge that we are trying to address with this bill. My real question, though, comes down to the alternative. All I hear is transparency with PBMs, and we've done some of that at the state level. Yes, we've had that conversation already, and we have not seen a drop in the price for your medicines that Big Pharma offers. What more do we need to do then? So if we're sitting here doing nothing as a state, which has happened, we've offered alternatives in the Senate. We're offering it again today. I'm open to an above-all approach to lower the cost of medicine. What is Big Pharma's approach, if not for trying something? We have addressed PBMs. We have done that at the state level with bipartisan support. We're now adding in a conversation around a board that would provide transparency and accountability to companies when they jack up the price of medicine with no explanation to consumers. What other ways can we address these exorbitant costs while your companies continue to rake in record profits?
I appreciate that question, Senator. And, I think one thing that we all face that is very frustrating is the opaque space in which these middlemen are playing. As states are taking action to increase transparency on PBMs. They are just making their way into other pieces of the market, such as TPAs. They're owning specialty pharmacies. So, they're finding other ways around the transparency measures, which then just make it all foggy again, and we're unable to really get any clarity into what's going on. Our solutions really focus around ensuring that the discounts are actually passed on to patients. So, when a patient is paying at the pharmacy counter, that impacts, that goes through their insurance, and the insurers and the PBMs determine what they're paying out of pocket while they are paying less due to the discounts and rebates that are provided, but then still charging full price to the patient. So we really need to see reforms on that side of the equation to really try to see some balance and really lower prices for patients.
So what I'm hearing is if we were to look at additional transparency throughout the rest of the system, you would support this legislation?
We are always supportive of transparency in the supply chain and happy to work with you on it.
All right, thank you.
Thank you. Senator Irwin.
Thank you, Madam Chair. You mentioned that states have spent millions but haven't seen an impact on prices yet. And, I might posit that that's because states have now finally started taking seriously the price gouging and abuse of our residents and started down this path of trying to lower prescription drug prices for their residents. But, of course, one of the stumbling blocks that other states have run into is opposition from big pharmaceutical companies, not just the sort of opposition that you're providing here today in committee, but also opposition in the courts. So when you look at the millions that states have spent to drive down prescription drug prices for their residents, are you aware of what percentage of those millions have been spent on litigation? And relatedly, is Amgen one of your members? Because that is the company that has been suing Colorado to try to prevent them from being able to address high prescription drug prices for their residents.
I am familiar with the litigation, Senator, and I would just, as pharma, we represent the entire industry as a whole, and we really don't have the ability to discuss or engage in any type of specifics on any company-specific litigation because we're not involved in that.
Is Amgen, the company that is driving the public cost of this litigation, a member?
They are a member.
Thank you.
Thank you. Any further questions? No, I appreciate your testimony today.
Thank you.
Next, we'd like to welcome up Scott Kempa, Legislative Coordinator, and Christine Shearer, Deputy Director of Legislation and Advocacy for Michigan Association of Health Plans, in support of the bills. Welcome.
Good morning, or good afternoon, excuse me. Good afternoon, Madam Chair Kavanaugh and members of the committee. My name is Christine Shearer. I'm Deputy Director of Legislation and Advocacy for the Michigan Association of Health Plans. MAHP represents 11 members serving over 4 million Michiganders in the Medicaid, Medicare, and commercial product lines. With me today is Scott Kempa, Legislative Coordinator for the Michigan Association of Health Plans. Thank you for allowing me to testify in support of Senate Bills 3, 4, and 5 today. Prescription drug affordability boards represent one of the most potentially impactful areas of legislation in the state-led effort to control drug pricing. In general, a prescription drug affordability board is comprised of a panel of experts charged by statute with identifying medicines that are of high cost burden to the state and its patients. This legislation would allow the Board of Experts the option to set upper payment limits or allowable rates for particularly expensive medications. These boards may also investigate abrupt medication price increases and act to counterbalance them. The National Academy of State Health Policy notes that these panels are intended to look at valuable drugs and determine at what cost they are affordable. At what cost will everyone who needs the drug be able to afford the drug? We all know someone whose life has been transformed by innovative life-saving medications. Thanks to advancements in treatment, many patients are now able to live longer, healthier lives with their loved ones. At the same time, We've likely encountered individuals who have had to cut back on or stop taking their medications simply because they couldn't afford them. This heartbreaking reality can lead to the worsening of their condition and poorer health outcomes overall. Rising prescription drug costs are a complex and urgent issue we must confront directly. It's essential that we work together to find meaningful solutions that improve healthcare affordability for all Michiganders. Drug prices continue to rise at rates far outpacing other consumer goods, making medications unaffordable for many and driving up healthcare premiums across the board. The time is to act now for the health and the well-being of our families, our communities, and our future.
Thank you, Madam Chair Kavanaugh, members of the committee, for the opportunity to speak today. So I'll try to keep my comments brief here, as I think a lot of this was covered as it relates to my remarks and some of the recent court actions and other happenings around the country. So just to address a few pieces here, as the legislature considered this critical legislation last session, we often heard from opposition, one, there was time that was needed for litigation to play out, a lot of questions about the constitutionality of PDABs, and then also citing concerns about access to treatments. So first, to address access, implementation of an upper payment limit is very unlikely to affect distribution of that medication in Michigan. Drugs are sold through many wholesalers who do business across the country, which would make it difficult, if not impossible, to restrict availability of a drug in one state. Manufacturers already sell the same drug to different stakeholders at many different negotiated discounts and rebates, with a goal of remaining competitive and expanding their market share. Maintaining the availability for their prescription drugs is also critical to preserving the company's reputation. The UPL will limit the cost of the drug, making it more affordable, possibly expanding access for more consumers and potentially even increasing sales. Regarding recent legal challenges, I know some of this has been discussed here a little bit already, but as some of you may have seen, on March 28th, 2025, Colorado's federal district court dismissed a challenge filed by Amgen against Colorado's Prescription Drug Affordability Board. They filed the lawsuit in March of 2024, arguing that the establishment of the Colorado PDAB and its actions were unconstitutional. And when the district court dismissed the case, their findings found specifically that Amgen did not effectively establish the company's profits would be reduced, citing counterintuitive pricing behavior across the pharmaceutical supply chain and the inability to predict a UPL. And they also found that the PDAB's actions impact only downstream transactions for the reimbursement, sale, and dispensing of prescription drugs to Colorado consumers. So in 2021, they enacted their legislation in Colorado with the goal of identifying unaffordable prescription drugs and improving access, just as we're attempting to do here today in Michigan. And it was mentioned in one of the previous, the physician offering testimony, they considered 5 drugs. 3 of them were selected in Colorado and deemed unaffordable. And just recently, just within the last couple weeks, on April 11th, my understanding is the Colorado PDAB just moved forward with their first hearing for one of the drugs they selected, Enbrel. So the establishment of that upper payment limit would be the first in the nation. So this case has been closely watched by those in Colorado, the 10 other states that have enacted a PDAB, as well as the 11 other states that are considering such legislation, including Michigan. So I will stop there. Thank you, Chair Kavanaugh, again for the time today, and members of the committee for the time this afternoon. I'll kick back to Chrissy.
In closing, as United States continues to grapple with prescription drug prices that are an average of 2.5 times more than any other country, 11 states have already taken action to establish a drug affordability board. 11 are pending. Here in Michigan, we call for action is clear. A recent poll shows that 87% of Michiganders across political lines support efforts to lower drug costs. of prescription drugs. We are here today to ask for your help in seeking health insurance affordability for Michigan families. We're asking for your leadership in addressing these unsustainable rises in prescription drug costs. We recognize the limits you face as state legislators in confronting pharmaceutical companies and unilaterally setting drug prices. However, the bill before this committee represents a meaningful and timely opportunity to take a stand, joining the growing number of states acting on behalf of their residents and responding to the voices of your constituents. Thank you for your time, and more than happy to answer any questions.
Thank you for your testimony. We do have a question from Senator Heisinger.
Thank you, Chair, and thank you both for your presentation today. I'll ask the same question I asked Dr. Davis, and will reiterate, too, that we should and can do things to help reduce our constituents' costs, but I'm not sure this is the right way. My concern is that Medicare reimburses based on the average sale price of that drug plus 6%. The state of Michigan has adopted the same policy, so our Medicaid pays ASP plus 6 as well. How will we handle the intersection where a drug that you find to be expensive, whether it's Enbrel or any of the other products that tends to be expensive, to be in the crosshairs where it doesn't match up with both Medicare and Medicaid reimbursement policy?
Again, thank you for the question, Senator. It's a very good question. My understanding is this will be a very small number of prescription drugs, and that the upper payment limit would go all the way through the system. So from the manufacturer to the wholesaler to the pharmacist, all the way to the patient. You could not sell it for more than the upper payment limit. So that would be different, but only for those set of drugs. So it would not abandon it for the rest of Medicare and Medicaid and what you suggest.
So if you sold a product or reimbursed a product that was in your managed Medicaid product category, that was based on the average sale price of that product plus 6%, and it happened to be something that you figured was an APL or UPL product, then you could lower that price, but the price is set based on the average sale price plus 6%, so they'd have to dispense or infuse that product at a loss?
I don't know. I think it would be at the UPL, and there would be time frame for the pharmacist to restock and whatnot on that. So that's my understanding, is it, we've got a chart on that just says it's
Yeah.
all the
We'll
way
dig into
around.
that more. Thank you.
Okay,
And we can
thank you.
definitely follow up as well. I know Senator Irwin has a question.
Yeah, I just want to know, I mean, I don't know if you can comment on this because it may be sort of atmospheric, but we've heard a lot of testimony today already, and we heard a lot last year from folks, and I've certainly heard it in my district, unsolicited, from folks who are saying, these prices are so high, and I'm forced to cut pills in half or not fill prescriptions. I hear from physicians who are saying, I prescribe a course of treatment, and people don't ever pick up the script because they can't afford it, and then it ends up immiserating them and costing us all more. Could you talk at all about how that impacts premiums broadly? Because, you know, I appreciate the emotional resonance, and it's probably the most important thing to start with, you know, how this impacts these patients and how it impacts people's access to health care. But what about those of us who are just paying premiums and are seeing those premiums go up and up and up, and we're seeing pharma become a bigger and bigger part of what healthcare is? It feels like these high runaway pharmaceutical costs are driving premium costs way up. So could you just talk about that relationship a little bit, even for those of us who might not be currently cutting pills in half or maybe not even on any prescriptions?
Yeah, absolutely. Great question, Senator Irwin. So as you know, we file our rates every year with our state regulators at DIFS and at the federal level. So we have to provide reasonable documentation for any impact to premiums whatsoever. So just in recent years, I know DIFS has noted the increase in prescription drug costs that health plans experienced during our most recent rate filings. I'm sure you've all seen some of the news coverage about premium increases here recently. MHP and our members can attest to that. Prescription drugs are the largest driving factor of premium increases today. I was just looking at some statistics earlier. When you look at the premium dollar, in 1990, pharmaceutical costs, I think, were a little over 5 cents on the dollar. Today, they're pushing 25 cents on the dollar. Prescription drug costs are the highest spend category in health insurance today. It outpaces inpatient, outpatient hospitalizations, and everything else.
Yeah, thank you for the answer. And just to respond briefly, even though this potential board to try to reduce prescription drug prices is only going to identify a few of the biggest outliers and is going to operate rather slowly, I still think it makes a ton of sense for us to identify some of these outliers and start to try to address this huge problem. So thank you.
Thank you.
Thank you. Any further questions from committee members? Thank you for your testimony. Next, I'd like to welcome up Jason Lakowski, Associate State Director, Government Affairs, AARP. Welcome to committee. There's a little button at the base of the mic. Perfect.
Chairwoman Kavanaugh and members of the committee, thank you for the opportunity to speak on Senate Bills 3, 4, and 5, which establish a Prescription Drug Affordability Board, or PDAB, in Michigan. I am Jason Lachowski, Associate State Director of Government Affairs with AARP Michigan, the nation's largest nonprofit, nonpartisan organization dedicated to empowering Americans 50 and older to choose how they live as they age. On behalf of our 1.25 million members statewide, AARP Michigan is pleased to offer our support for Senate Bills 3, 4, and 5 to establish a PDAB to help rein in the high cost of prescription drugs in Michigan. PDABs are independent bodies established by the state to evaluate drug prices and set limits on how much certain payers, including state agencies, will pay for high-cost prescription medications. AARP supports the development of state drug affordability boards and believes that federal, state, and local governments should ensure that prescription drug launch prices and subsequent pricing decisions are reasonable, justified, and support improved consumer access and affordability. Lowering the cost of prescription drugs is a high priority for AARP. According to a survey conducted by AARP in 2022, 3 in 4 Michiganders report taking prescription medications on a regular basis, and 58% cite not filing a prescription because of cost. Older adults are disproportionately affected by high prescription drug costs, with 40% taking 5 or more medications and nearly 20% taking 10 or more. More than half, 57% of Michigan adults 50 and over, are concerned they will not be able to afford a prescription drug over the next few years for themselves or their families. Consumers have faced unfair drug prices for years, and the situation has only gotten worse. A recent report by the U.S. Department of Health and Human Services noted that list prices on more than 1,200 medications rose faster than the rate of inflation, rising an average of 31.6%. Furthermore, high drug costs hurt everyone, not only those who rely on prescription drugs for health, but all those who pay higher premiums and out-of-pocket costs, as well as taxpayers who fund public programs. The current high cost of prescription drugs is outrageous and unsustainable, which is why Michigan voters are demanding action. According to a survey conducted by AARP in October of 2024, addressing the cost of prescription drugs was extremely or very important to 65% of Michigan voters age 50 and older. Under this package of bills, the board would be able to review drug prices that pose an affordability challenge and set upper payment limits that apply throughout the healthcare system to protect consumers, state and local governments, providers, and all stakeholders. We urge you to support Senate Bills 3, 4, and 5 to help ensure that Michiganders can access and afford medications they need. The best drugs in the world don't work if you can't afford them. Thank you for your time and consideration.
Thank you for your testimony. Any questions from committee members? No, appreciate your time. Next on Zoom, I'd like to welcome Rainer Simmons, State PDAB Policy Director at Community Access National Network, opposed to the bills.
Hi, good morning. Can you hear me okay?
You're a little bit low, but I think we can hear you.
Let's see. Is this better?
This is better.
Okay, hi, good morning. Hey, my name is Rainier Simons. I'm representing the Community Access National Network, and I'm speaking today in opposition of the bills, mainly Senate Bill 3, and since it's the main bill and its counterparts. While the bill's purpose is to lower costs, it actually does not consider many hidden costs. For example, the Oregon Prescription Drug Advisory Board, they did their analysis conducted by an independent consulting firm, They found that an upper payment limit would likely result in a reduction of rebate values across the board. This would harm the Medicaid program by reducing federal matching dollars. The reduction in rebates would also adversely affect safety net provider sustainability and the AIDS Drug Assistance Program by reducing 340B program funding. In order to sustain these programs serving marginalized and impoverished communities, under a UPL, the state would need to appropriate additional dollars for programs and providers to make them whole, or risk reducing services to the populations in need. Also, the legislation also focuses heavily on wholesale acquisition costs, or WAC, in selecting drugs for affordability review. This is the inappropriate metric. Complaints filed by the Federal Trade Commission against the largest pharmacy benefit managers delineates their profiteering manipulation of wholesale acquisition costs, which adversely affects patients' access and affordability to medications based on the potential for PBM profit, not the list price of medications. When manufacturers offer PBMs lower WAC medications that are clinically identical to high WAC versions, PBMs choose the high WAC versions for their patients. Additionally, the upper payment limit is essentially a reimbursement cap, not a mechanism that will result in direct savings to patients at the counter. Analysis from multiple insurance plans report that the UPL would likely not result in any savings to patients. It could actually negatively affect patient access and in some cases actually increase costs for patients. Lastly, as mentioned before previously, many states have already instituted active prescription drug advisory boards, and those boards have spent millions in taxpayers' dollars without achieving any savings at all for the patients. No upper payment limits have been set, and at this time there is no prediction of when they're going to be set. A more effective way to achieve savings would be to pursue even more effective PBM reform, since PBMs are the orchestrators of the cost sharing requirements for insurance plans. Additionally, Medicaid audits are an effective means to realize savings. The state of Indiana discovered several $100 million in Medicaid fraud after auditing its program and its associated Medicare organizations. Additionally, I'd like to add that affordability is not just about the list price of a drug. Affordability is encompassed by many things. Additionally, one of the previous persons testified mentioned some of the patient assistance programs that are provided by some of the drug companies. The reason that Colorado actually cited one of their drugs was actually deemed affordable was because they found that because of the patient assistance programs, that patients were able to affordably get those drugs. So the prescription programs that manufacturers provide to assist patients with drugs and the coupons and things of that nature are a help to patients. Thank you.
Thank you for your testimony today. Any questions from committee members? No, I appreciate your time. Next on Zoom, Fox Rigney, patient, Michigan resident living with multiple sclerosis.
Thank you so much, Committee Chairwoman Kavanaugh, and everybody on the committee. I appreciate you hearing me today. And as we just indicated, I am Fox Rigney. I live in Lakeview with my wife, Jen, 2 stepchildren, a domestic farm of animals, and I'm here because I am among the nearly 40% of people living with multiple sclerosis who have altered the use of their medication due to cost. Before I was diagnosed 13 years ago, numbness and tingling started in my right hand. Then, while training new runners to complete their first 5K, I, a lifelong runner, could not keep up with them. Escalating the situation and changing doctors quickly led me to my multiple sclerosis diagnosis. I was initially prescribed Betaseron, a self-injected disease-modifying therapy, or DMT, that has been shown to modify the course of MS and prevent the accumulation of disability. Symptoms and prescription therapies vary widely due to how unpredictable the disease can be. I tolerated Betaseron for 1 year and transitioned to Gilenya, a daily pill, which I was on for 6 years. I then started Ocrevus, a twice-yearly infusion, which I was on for a year. I'd also like to make an added note that in the written testimony submitted by Anna Meyer from the National MS Society, you'll see a graph that shows how expensive these medications are. with Betaseron having an annual manufacturer price of over $126,000 and Gilenya having an annual manufactured price of over $129,000. Now, I was here last time giving testimony, and I was looking at my last testimony, and those have gone up by multiple thousands of dollars since I was here 18 months ago. With each transition came a new price range. Fortunately, I have employer-sponsored health insurance. Between health insurance and co-pay assistance, I paid little or nothing for those treatments. However, because I know jobs can come or go with the swing of the economy, and it is a little precarious right now, I felt forced to always hedge my bet. First, I did not take my Gilenya as prescribed by skipping days so I could accumulate a 6-month surplus. In the event something happened to my jobs, because as I went over those numbers, that is unattainable for somebody without insurance. I then was given a choice by my neurologist of 2 top-tier medications because my disease continued to progress. And I made the choice to go with a medication called Mavenclad. And that was not what was recommended by my physician. So I went against his recommendation, although, yes, he gave me the 2 options. And I solely made that decision on one and one reason only. If I took Mavenclad, and everything worked out perfectly, I would not have to take any DMTs moving forward. And it was really all financially based. So I didn't have to worry about these nonsense prices of these drugs. And I could just, I could take that off the plate, take that off the worry. So I want to be clear. Skipping doses medication and making decisions out of step from my neurologist due to cost and not health outcomes should never be the norm. However, as I said before, in a recent study done by the National MS Society, over 40% of people living with MS are altering their treatments, just like me. And every new lesion on our brain and spine due to lapses in treatment, it's irreversible. That's a step into disability we are not going to step backwards from. So I strongly feel that no one should have to make these kind of decisions. Medication cannot improve lives if people cannot afford to access them. So thank you for hearing me, committee, and thank you for considering taking steps forward with a prescription drug affordability board. I appreciate you.
Thank you so much. I'm sorry for your experience and having to make hard decisions when we really shouldn't have to for our health. And thank you again for coming back to give some testimony. We do have 2 more, so I do want to move on to another Zoom testimony. Chris Kennedy, former Colorado State Representative and Colorado PDAB bill sponsor, who is currently not on the call, so we'll jump right into Justin Mendoza, Executive Director of Universities Allied for Essential Medicines.
All right. Thank you, Chairwoman Kavanaugh and the members of the Finance, Insurance, and Consumer Protection Committee. Thanks for hearing my testimony today. My name is Justin Mendoza, Executive Director for Universities Allied for Essential Medicines. For the last 24 years, we have positioned ourselves at the forefront of innovation and access to life-saving medicines around the world. We represent more than 4,000 students and academic researchers across the country, including researchers and students here at the University of Michigan. When a patient faces a price increase on at least one prescription, you've heard testimony today, they're twice as likely to skip doses, cancel medical appointments, or even purchase fewer groceries for their family. And I've heard you all say you agree that this is an important topic to address. But while the consumer suffers, drug makers lobby. so they can enjoy unchecked prices and reap windfall profits. In 2024, just last year, the pharmaceuticals and health products industry spent more than $380 million lobbying the U.S. Congress alone. And it's no surprise to hear industry voices today testify with the same talking points that they've been using for the last 30 years about innovation and drug pricing, and pointing the finger at other members of the supply chain. When Michigan, one of the largest states in the nation, considers using its power to review drug costs and potentially set upper payment limits. In 2015, a bipartisan committee, led by U.S. Senators Ron Wyden and Chuck Grassley, actually investigated the introductory price of a $1,000 per day pill called sofosbuvir. They uncovered in that investigation a color-coded chart that articulated a number of factors that were used to decide the final list price of that product, including the opinions of lawmakers, patient advocates, statements and views of the insurance companies, physicians, and other key stakeholders. Nowhere in their allocation was research and development costs or manufacturing costs of the product itself. Any reasonable interpretation of that data gives us the impression that setting the drug's price is just a political act, rather than one based on the actual realities of the business. But let's talk about the big picture. The biggest lie, really, in drug pricing, which is that corporations are the biggest innovator. In fact, as Senator Camilleri mentioned before, the U.S. taxpayer invests quite a bit on the riskiest portion of research and development, which is the basic science. A lot of those basic science products do not make it to market. But the U.S. government spent $48 billion in 2024 on basic science research, taking on the most risk so that industry can pick it up from there. And oftentimes, pharmaceutical corporations will claim that R&D costs as high as $2 or $3 billion for their product. Yet, looking at a systematic review of pharmaceutical research from 2000 to 2018, the mean or average for developing a drug was just $172 million in real costs. And if you account for loss of capital and losses for other research ventures that don't pan out, it ends up increasing to just over $800 million, 2 to 3-fold less than corporations will claim when they testify before your body. But each drug is different, which is why a Prescription Drug Affordability Board that reviews the data, takes a look at the circumstances that apply, and applies that data in its recommendations is in order, rather than just taking a look at the amounts claimed for R&D in a press release. Drug prices also continue to climb every year on drugs that already exist. For instance, the beginning of 2025, the prices of more than 575 drugs that were already on the market saw an increase on average of 10%. So consumers are paying for medicines they've already taken, and they're paying more than inflation. And where exactly are these dollars being spent? Well, outside of lobbying, which we talked about before, stock buybacks and executive compensation. From 2012 to 2021, the 14 largest pharmaceutical companies in the world spent more than $740 billion in stock buybacks. During that same time period, they spent $640-ish billion on research and development, so a little bit less than they were spending on just paying their executives and shareholders out. The PDAB will at least add some leverage to ensure that Michiganders can afford the medicines that they need. These bills, which we encourage you to support, would put a cop on the beat, for lack of a better phrase, to make sure that prescription drugs are affordable for all consumers here in Michigan, and is based off of the success that we've already heard other testimony about in other states so far. It's time for Michigan to use the power of our market share to pressure these companies to play ball, and it's time to pass the Prescription Drug Cost and Affordability Review Act.
Thank you for your testimony. Any questions from committee members? No? Thank you for your time.
Of course.
And with that, I'd like to ask the clerk to read in the cards for the record.
On Senate Bills 3, 4, and 5, Chris Baggett, Takeda Pharmaceuticals opposes. Gabe Basso, Blue Cross Blue Shield supports. Elizabeth Cutter, Michigan Health and Hospitals supports. Amy Stanton, MESA supports. Dave Worthams, Michigan Manufacturers opposes. Jackie Dolce, Grand Rapids Chamber opposes. Amber Belizaire, Michigan League for Public Policy supports. Amar Majou with Michigan Rheumatism Society opposes. Madeleine Fellman, Coalition for State Rheumatology Organizations opposes. David Gunther with Mackinac Center opposes. Maima Carmo, Tiger Lily Foundation opposes. Michiel Peters, Global Coalition on Aging opposes. Anna Meyer, National Multiple Sclerosis Society supports. Shabir Safdar with the Partnership for Safe Medicines opposes. Stephen Rependalo with MishBio opposes. Wendy Block, Michigan Chamber opposes. And on Senate Bill 3 alone, Philip Kuriakose and Eric Weiner on behalf of the Michigan Society of Hematology and Oncology and the Association for Clinical Oncology took no position. Eric Roth, Michigan Pharmacists Association opposes, and Travis Buccello, Healthcare Distributors Association opposes.
Thank you. And due to these bills having come before this committee before, as well as months of ongoing stakeholder discussions, we will be voting these bills out today. I do want to hand it over to my colleague, Senator Heisinger, for some comments.
Thank you, Madam Chair. As I have extensive experience in the healthcare space and consulting and potential conflicts of interest, I will not be voting today. I'll be taking a pass on both, all three bills, Senate Bill 3, Senate Bill 4, and Senate Bill 5. Thank you so much.
Thank you. I will now entertain a motion to report Senate Bill 3 as substituted to the floor with recommendation that the bill pass. So moved by Senator Camilleri. Will the clerk please call the question?
I'm reporting Senate Bill 3 as substituted. Chairwoman Kavanaugh.
Yes.
Senator Irwin.
Yes.
Senator McCann.
Yes.
Senator Bayer.
Yes.
Senator Camilleri.
Yes.
Senator Heisinger.
Pass.
Senator Tice.
No.
Senator Daley.
No.
Madam Chair, there are 5 yeas, 2 nays, and 1 pass. The bill is reported.
Thank you. I will now entertain a motion to support Senate Bill 4 to the floor with recommendation that the bill pass. So moved by Senator Bayer. Will the clerk please call the question?
I'm reporting Senate Bill 4. Chairwoman Kavanaugh.
Yes.
Senator Irwin.
Yes.
Senator McCann.
Yes.
Senator Bayer.
Yes.
Senator Camilleri.
Yes.
Senator Heisinger.
Yes.
Senator Tice. Senator Daley.
No.
Madam Chair, there are 5 yeas, 2 nays, and 1 pass. The bill is reported.
Thank you. And lastly, I will entertain a motion to report Senate Bill 5 to the floor with recommendation that the bill pass. So moved by Senator Irwin. Will the clerk please call the question?
I'm reporting Senate Bill 5. Chairwoman Kavanaugh.
Yes.
Senator Irwin.
Yes.
Senator McCann.
Yes.
Senator Bayer. Senator Camilleri.
Yes.
Senator Heisinger.
Pass.
Senator Tice. Senator Daley.
No.
Madam Chair, there are 5 yeas, 2 nays, and 1 pass. The bill is reported.
Thank you. And there being no further business, the Senate Committee on Finance, Insurance, and Consumer Protection is now adjourned.